We're going to make a start now. So can I just ask all participants to turn off their microphones and cameras for the event, please? Many thanks. So my name's Matthew Philpott, and I'm Executive Director of Health Equalities Group, and we're the host organisation for Food Active. Can I just start by offering a very warm welcome to all of our delegates today, and of course thanks in advance to our speakers who are joining us for this year's Food Active conference. Today's conference is a little bit different to previous years, usually held in central Manchester. 100 or so delegates crammed into a room with train delays, traffic jams, even flooding last year, playing havoc with our schedule. We'll undoubtedly miss the atmosphere and the networking opportunities our delegates bring to the conference, but hope we can capture at least some of that energy through this year's online event as well. Now, the more observant of you may have already spotted that, in fact, I am not Janelle De Grucci, who is billed as chairing today's event. As you can well imagine, Janelle, as president of the Association of Directors of Public Health and DPH for Tameside, her time is pretty limited at the moment, and she's required to attend another meeting today until mid-morning. However, I am pleased to let you know that Janelle will be able to join us later in the day, and she will chair the Directors of Public Health panel discussion from 10:40 onwards. So turning to today's event and its aims, we're delighted to have over 300 delegates registered for the conference today, and a fantastic programme of speakers setting us up for an exciting and thought-provoking event. The main aim of today's conference is to explore opportunities to promote healthier weight and reduce health inequalities as part of building back fairer in the age of COVID, to paraphrase one of Sir Michael Marmot's calls to action. Over the course of the morning, we will explore evidence linking COVID-19 outcomes with higher levels of obesity and health inequalities found in the north of England. We'll showcase examples of good practice promoting healthy weight at a local level during the COVID-19 pandemic, and we'll discuss the barriers and opportunities faced at local level through a series of themed workshops later in the morning. Before we get started, just a few housekeeping points to help the conference go as smoothly as possible, please. As there are so many delegates on the call, please can you make sure that you mute your microphones and turn your cameras off at all times, please. You should have all received the conference programme by email ahead of today's event, and please refer to this for the full agenda and for information on today's speakers. We'll have time for Q&As at key points during the event, and we'll be using the chat function at the bottom of your screen for delegates to send their questions to the Food Active team, who can then field that to our speakers. Please do join in the conversation on social media, tagging in @FoodActive and using the hashtag FAConf. And please note that we are going to be recording this event, and whilst all presentations will be circulated to attendees next week. Now, we're on a really tight schedule, so thanks again for joining us, and I'm going to hand over to Alex Holt, who is Food Active's programme lead, to give a short introduction to Food Active and our work. Alex, over to you.
Thanks, Matthew. I'll just get my screen up one moment. Hopefully you can see that okay. Hello everybody. So my name is Alex Holt. I'm the Food Active Programme Lead, and I'm just going to spend 5 minutes giving you a little bit of background about the programme.
Alex, sorry.
So Food Active, sorry,
I can't see your slides, Alex.
You can't see my slides? Oh gosh, sorry. One moment.
There we are.
How's that?
That's perfect.
Okay.
Thanks, Alex.
Apologies for that, everybody. Okay, that was the first slide. Okay, on to the second one. So Food Active is a healthy weight programme. Programme delivered by the Health Equalities Group and commissioned by local authority, public health teams, NHS organisations and Public Health England teams at a regional level. Food Active is one of 2 programmes delivered by the Health Equalities Group. Our sister organisation, Healthy Stadia, uses the power of sport and physical activity to improve the health and wellbeing of fans and local communities. We work quite closely with Healthy Stadia on a number of projects, including Give Up Loving Pop and the Healthy Match Mark. So the Food Active programme was set up by North West Directorate of Public Health in 2013. The then named North West Obesity Task Force was officially launched as Food Active in 2014. The programme focuses on advocacy, targeted interventions, research and strategic partnerships to drive forward policy calls. So obviously originating in the northwest of England, Food Active supports local authorities across the region, both on an individual level, but also in taking a collaborative approach to promoting healthy weight. More recently, we've worked to support local authorities across England, from the northeast and Yorkshire and Humber to the southwest, to help drive forwards the healthy weight agenda. So just a little bit about what we do. So we're a network of independent collective voices of local authorities, all with the same objective of promoting healthy weight locally. We're an independent charity. We're able to lobby and communicate sensitive and political issues. We are a collective to share good practice. And finally, a forum for learning and discussion, with today's conference a key example of this. So Food Active's core aim is to address the social, environmental, economic and legislative factors which influence people's lifestyle choices and behaviours, with a specific focus on healthy weight. So as you can see on the screen, there are three key aims. The first is to influence policy, and this is what we frame our work programme around. So influencing policy, we work to influence policy pertaining to healthy weight at both a local and national level. We deliver interventions and campaigns to promote healthy weight, and with a focus on populations who suffer the greatest level of health inequalities. And we undertake research and develop strategic partnerships to lobby and advocate on issues pertaining to unhealthy weight and the impact of both the food and the built environment. So just to give you a little run through of some of our key projects and campaigns. The Local Authority Declaration on Healthy Weight was launched back in 2015 and is a strategic system-wide commitment made across all departments within the council to reduce unhealthy weight in local communities. The declaration has now been adopted by 22 local authorities in the north of England and 25 nationally, with many more working towards adoption despite the challenges that COVID has brought. More recently, over the last 18 months, we've been the delivery partner for the Pennine Lancashire Childhood Obesity Trailblazer programme, Healthier Place, Healthier Future, funded by the Department of Health and Social Care and led by colleagues in Blackburn with Darwen and East Lancashire. The programme takes a system-wide approach to harness the power of 4 levers to tackle obesity across the footprint. They are system leadership, business engagement and support, positive planning possibilities, and community-led action through social movements. As we're quite tight on time, I won't go into much more detail, but as you can see on the screen, there's a few more of our key projects there. If you'd like any more information, there is some blurb in the campaign conference handbook, and also you can either visit the website or just drop us an email if you'd like any more information. So just a final slide to reference today's conference. So it's clear that for many of our deprived communities, the impact of COVID has been felt the greatest, with inequalities and poor health prior to the pandemic being heightened even further. We of course realise that many will have suffered regardless of health status, weight status or affluence, but there is evidence to suggest that the economic and health impact of COVID has been felt greatest in the north of the country. And whilst we're very much looking forward to the evidence today, we're very interested in the discussions about how we can level up. Okay, thank you for listening.
Thanks very much, Alex. That's a great overview of the work that Food Active are undertaking, and hopefully some of the aims and outcomes of today's conference. I'm going to move straight on to 3 presentations now that will be followed by a Q&A session. We're going to hear from Luke Munford, who is from University of Manchester, and then following that, Anna Taylor, who's Executive Director of the Food Foundation. And then our third speaker on this session will be Charlotte Hardman from University of Liverpool. I'll let them introduce their own presentations. So Luke, it's over to you. Many thanks for speaking.
Thank you very much, Beth, Matthew and Alex, for the invitation to talk today. Hopefully everyone can see my screen okay. So I'm going to talk about is COVID-19 and inequalities, particularly through a north-south lens. But I'm also going to talk about what the state of affairs was before COVID and how these two things link together. So I'm Luke Munford. I'm a lecturer in health economics at the University of Manchester. But the work I'll be talking about today is very much a collaborative effort with lots of colleagues throughout the north of England. So the work will be based on these two reports. A report in 2018 looking at the relationship between the regional inequalities in health and economic and wealth outcomes. And then a follow-up report that we published at the end of last year, looking at how COVID-19 had disproportionately affected the north of England. So at the beginning of the pandemic was this idea that we're all in it together. COVID was a great leveller. But as the pandemic evolved, we quickly realised that this wasn't the case, and that the most vulnerable groups before the pandemic were again more adversely affected than some other groups. And these two reports were commissioned by the NHSA, who are an umbrella organisation in the north of England that bring together universities, NHS trusts and applied health science networks. So what was the state of play before COVID-19 with respect to health inequalities? So what we have here is life expectancy in 2018, 2019, across the East Coast, West Coast and Great Western Railway lines. Stations that are in amber have life expectancy round about the English average. Stations that are highlighted in green have life expectancy below the English average. Above the English average, and then stations in red have life expectancy below the English average. And what very quickly becomes apparent from these two visualizations is that places in the north of England have lower life expectancy than their compatriots in the south of England, and this sort of shows us quite nicely. But this gap in life expectancy is actually being grown over time. It's not getting better, things are actually getting worse. So what we do is we consider the northern powerhouse, which is essentially the northeast, the northwest, Yorkshire and Humber, and a tiny bit of Nottingham and Derbyshire. And we compare this to the rest of England. So the lines at the top for both females and males are the rest of England average life expectancy at birth. And the purple lines at the bottom are the corresponding values for the northern powerhouse. In the early 2000s, this gap was about a year, 1.5 years, which has slowly grown over time to over 2 years gap in life expectancy. And we can see there's a stagnation in life expectancy in the 2010s, and this is strongly correlated with reductions to local authority public health budgets and the austerity programme from the 2010s. Quite alarmingly, for the first time ever, in about 2014, 2016, we saw decreases in life expectancy, particularly for females in the north of England, and again, particularly in deprived areas that couldn't really afford to have these cuts to public health budgets, and the effect of this was a slowing down and a decrease in life expectancy. Other health outcomes differentially spread across the country. So there are more cardiovascular deaths for those under 75 in the north, about 16 more per 100,000 every year. There are more cancer deaths among the under 75 in the north than there is in the rest of England. There's a higher prevalence of diabetes, and importantly for this particular conference, there's a higher prevalence of obesity and overweight in the north. And we can see that here. So we've got the 9 regions in England down the y-axis, and then the prevalence of obesity and overweight in 2019. So the 3 areas in the north, the northeast, northwest, and Yorkshire and the Humber, are all comfortably above the English average, and the areas in the south, southeast, southwest, and London are all comfortably below the English average. I mean, these figures are quite worrying anyway. So over 62% of the English population on average is classified as obese or overweight, and again, this is more concentrated in the north. The same is also true for school children. So the blue bars at the top for each region are for reception children, age 4 to 5, and the orange bars at the bottom in each region are the corresponding values for children in year 6, age about 9 or 10. And again, the north is at the top of this leaderboard, so they've got the highest prevalence of obesity in both reception and year 6. And typically the south of England has lower than English averages, with the exception of London in year 6. And this is important because childhood obesity feeds through into adult obesity, and obesity is so strongly predictive of a lot of adverse health outcomes. So we really do need to try and tackle this, particularly in the north of England. So if we link this to regional economic inequalities, obviously health is really important, but government and policymakers seem to unfortunately take much more notice when you translate this into economic and monetary outcomes. So on the left is job density, and that is essentially how many jobs there are per person. So in the northeast of England in 2018, for every 100 people who wanted a job, there were only 73 jobs. So 27% of people who wanted a job in the northeast didn't have a job for them to go to. And the average in the north was about 79 jobs per 100. If we compare this to London, you can see there's over 102 jobs per 100 people. And the southeast and southwest also does much better than the north. So there's disparities about where jobs are available. And on the right-hand side of this slide, if you are lucky enough to have a job in the north, your salary is much lower than if you're in the south. So the average salary in 2019 in the north was £23,200 a year, compared to 24,700 in the rest of England, excluding London. And then when we include London into the rest of England, this goes up again. But London is such an anomaly with salaries, we compare the north to the rest of England, including and excluding London. And again, this gradient is true for both males and females. So there are differences in the availability of jobs and also the salaries, even if you're lucky enough to have a job. So this all leads to lower productivity. Gross value added is a subnational measure of gross domestic product. So what are the value of goods and services produced by local areas? And we can see in the north, the green line at the bottom, this is substantially lower than the rest of England. And from 2010 to 2018, the GVA increased by 6.6% in the north compared to 10.1% in the rest of England, including London. So this is quite worrying because the levels are already lower and they've grown much slower. So this gap is continuing to widen. It's not narrowing. We don't think it will narrow unless drastic action taken really soon. In 2017, the gap between the north and the rest of England was estimated to cost the Treasury about £44 billion a year. So if this gap was completely eradicated, an extra £44 billion would be put into the Treasury budget a year, which is a big ask to completely eradicate the gap, but this is the size of the gap. And even if we make incremental steps to reduce this, there'll be a lot of money put back into government. In our 2018 report, we estimated that about 30% of this gap in productivity between the north and the rest of England could be directly attributable to health. Obviously, this is going to be a very conservative underestimate because health will also affect education, people's job opportunities, people's ability to remain in the job, and lots of other aspects of their lives. But if we can reduce the health gap between the north and the south, completely eradicate it, at a minimum, it will put £13 billion a year into the Treasury coffers. But this is substantial amounts of money we're talking about. And this is over and above, obviously, the holistic value of health and how people's health will improve and they'll feel better. So there's all sorts of benefits that improve in people's health. And if we improve the weight of people in the north, we know that this is a very good starting point to reducing this health inequality. So that was all pre-COVID. What's happened during COVID? Unfortunately, it's quite an alarming picture. So this is heat maps of England for mortality rates in March to July 2020, so the first wave of the pandemic, where areas, local authorities in dark red have the highest mortality rates and the beige have the lowest mortality rates. And you can see there's very clustered areas of high rate of mortality, particularly in the northwest, so Manchester, Liverpool, in Yorkshire, so Sheffield, Leeds, and also up in the northeast, Durham and Newcastle. And this is true for both COVID and all-cause mortality. London also has very high rates of COVID, but we know they were the epicenter of the first wave of the pandemic. So just looking at unadjusted rates in the first wave, so we can see there's a huge amount of regional variation. So this pandemic didn't affect all the country equally. The south, with the exception of London, did far better. So the southwest and the southeast had low average mortality rates. And again, the Yorkshire and Humber, northwest and northeast had above English average mortality rates. London is the exception, but we can see that London was very much driven by March and April, where London was very hard hit at the beginning, but then from May onwards, actually, it had below average rates of mortality, but the north continued to have high rates even through the later waves. And the same is also true for all-cause mortality. So COVID mortality was important, but we need to remember that there was indirect effects of the pandemic as well. And here we see a more traditional pattern, what we expect from previous years, where the southeast, southwest are the bottom, and the three regions in the north are towards the top. Even though London had such high mortality due to COVID-19, its all-cause mortality was still substantially below the northeast and the northwest. And again, we've got this temporal variation. So London was hit hard first, but then very quickly reduced below English averages, whereas the north stayed well above average for the majority of the month. If we look at the areas that were worst and least affected by the pandemic, so for COVID-19, the least affected areas were all in the southeast and southwest, and the highest affected areas were all in London. And this is again driven by what happened in the early months of the pandemic. The all-cause mortality rates for the same period tell the traditional story. So the southeast, southwest, and London do better than the English average, and the northeast and the northwest dominate the worst mortality rates. So Burnley is highlighted here as an interesting case study. So we did some work with the BBC, who did a lot of in-depth interviews in Burnley. And they found that actually the direct effects of COVID weren't felt so badly here, but the indirect effects were. So the mortality rate in Burnley for COVID was below the English average, but the all-cause mortality rate was substantially above the English average. And this was attributable to people not going to the GP and the hospital for routine care because they were scared. They'd seen a lot of bad stories about what was happening in hospitals. Although the mortality rate for COVID was low, the all-cause mortality rate was very high through indirect effects and through reductions in routine care. All of that was unadjusted, but we know there's substantial differences between the north and south in lots of areas. The north and the south have different age structures, they have different ethnic profiles, and they also have different levels of deprivation. So on average, the north is more deprived than the south. And we know that deprivation, ethnic structure, age structure, education all predict mortality rates. What we want to do is try and account for these in some way, so we make a more direct comparison. Even after we do that, the mortality rates attributable to COVID-19 were substantially higher in the north than the rest of England. I think this is quite worrying because we thought that the differences might be due to underlying factors such as deprivation and structures of the population. But this is rebuking the idea a little bit and saying that actually there are still factors that are different in the north that makes it more susceptible to worse health outcomes. So there's unobserved things in the north that are making the north more susceptible to these adverse health effects. And again, this is also true for all-cause mortality, but there's something in the north that makes it more vulnerable than the south, even after we account for lots of factors that we know cause mortality rates. Mortality is obviously really important, but there are other effects of people's lives that were affected by the pandemic. So mental health is a big one. And what we have here is reductions in mental health from 2019 to May 2020. So the same people were followed up, and we know what the mental health was before the pandemic and what it was like in the middle of the first wave. Every area of the country experienced substantial reductions in mental health. But again, this was far more prevalent in the northwest, northeast, Yorkshire and Humber. So there are effects over and above mortality that are being affected worse. What do we think this will mean for the economy in the north? So there's a strong association between mental health and productivity. This data is all based on pre-COVID. We know this is going to get a lot worse. But at best, we think the reductions in mental health in the north will cost an additional £5 billion in lost productivity. And again, this is a very conservative estimate because there's all sorts of other things going on due to the pandemic. Unemployment is really important because we know unemployment is so predictive of future mental health. People become unemployed more likely to report depressive symptoms. And again, the level of unemployment in the north pre-pandemic was well above national average. And unfortunately, the rate of growth of unemployment in the north was a lot faster than the rest of the country. So this is sort of unfairness on top of unfairness. The north already had more unemployment and it's got worse a lot quicker. I think, as we've said, this is really important. It really does need to be watched quite closely because this is so predictive of future health outcomes. And we know unemployment and overweight and the way people eat and the way they exercise are related. So we need to keep an eye on what people are doing and really try and look after these people to protect them. We considered a lot of other measures. So loneliness, people were more likely to report feeling lonely in the north than the rest of England. And this is important because loneliness again affects mental health, how people feel about themselves, and also how they eat and exercise. There was substantially higher rates of furlough in the north, particularly in deprived communities. If you were lucky enough to keep your job and you weren't put on furlough, your hours were much more likely to reduce in the north than the rest of England. There are higher levels of universal credit claims pre-pandemic, and again, this grew much faster in the north. So everything we looked at was worse in the north, and it was hit harder in the north than it was in the rest of the country. So we haven't really considered direct weight obesity outcomes as yet because we haven't got the data, but this is now starting to come out and we are analysing this, and we expect to see similar patterns to what we would expect, and that these will be affected worse in the north. And the report had a series of recommendations, and I think the key one is to put health at the heart of everything government and local authorities do. Because if we can get health sorted, reduce health inequalities, we know that the other aspects of people's lives will follow behind. So health is so important to people, to enable them to work, to enjoy their lives, to have a fulfilled life, that if we get health right, we think that everything else will follow behind. So thank you very much for the invitation to talk today. The two reports are available online, and I'm very happy to be contacted by people about the report and see what you think. Are we missing some outcomes? Are there possible explanations to what we find over and above what are in the report? So please do get in touch with any thoughts and suggestions. So thank you very much.
Thank you very much, Luke. That was absolutely fascinating. Really interesting to hear about not only some of those outcomes that affected the north disproportionately, but also those preconditions around health and economic inequalities that have affected things and led to those terrible outcomes that the north has faced over the last 10 months. Really interesting to hear. 13 billion saved if the north-south gap can be dissolved. I think that's a figure to hang on to for now. Okay, we're going to look a little bit more at COVID inequalities and healthy weight now, and we're going to turn to Anna Taylor, who is Executive Director of the Food Foundation. So Anna, the floor is yours.
Thank you very much, Matthew. I'm going to try and share my screen and hopefully this will go okay. Is that working?
That's wonderful. Thanks, Anna.
Brilliant. Thank you ever so much for the invitation. It's a real pleasure to be here and to have the chance to discuss this issue with you all. So I'm Anna. I head up the team at the Food Foundation. If you've not heard of us, we're a charity working to try and change the food system to deliver healthier and more sustainable diets for everyone, but particularly those on a low income. Focused across the UK. And during the COVID pandemic, we've been doing a series of surveys to try and understand access to food. We've done now 7 surveys. We've got our next one in the field at the moment. So I'll be drawing on some of that data today, but wanted to also set it in the context of what we know about dietary inequalities before the COVID pandemic. I think there are 4 or 3 kind of key messages really that I'd like to get across in the presentation today. The first is really that food insecurity and obesity might on the face of it appear to be strange bedfellows, but in fact they're very close bedfellows. Secondly, income and food environments matter. We can't separate these two factors when we're looking at dietary inequalities. And we had a very serious situation before COVID, which has got worse and is likely to get even worse. And I'll end with a little bit of discussion about some of the things that we're focusing on in terms of what can be done about it. But those are at the national level, and I know that there'll be further conversation today about sort of 8-point plan, which is being put to the Metro Mayors in the North. So interested to see how those two things connect. So let's start by let me just get this going right. Okay, so what I'm going to be presenting at the beginning here is a lot of data from our Children's Right to Food dashboard. We launched this back in September last year, and there's going to be a link to it at the end. But it's got a wealth of data around diet, food environment, coverage of government programmes, and it's a mixture of UK and devolved. It's mostly England and UK at the moment. We're still to add data for Scotland, Northern Ireland and Wales. But would welcome feedback from it. If you do find it useful, let us know, or if there are other things you'd like to see appearing on it, let us know. But it's basically drawn almost exclusively on national data sets, pulling out key elements of those data, which are often hard to find in one place, so that you can grab them easily. These are the childhood obesity statistics, which you're no doubt very familiar with, broken down by deprivation. And I think the important point to note here is that we've had severe dietary inequalities reflected in childhood obesity rates before COVID happened, and importantly, those differences are widening between the most deprived decile, shown on the top of the graph in the green line, and the least deprived, shown in the red line. And then this is just one other set of outcome data. This is pediatric type 2 diabetes, which we all know is on the rise, and quite shocking data in terms of the concentration of these children in different quintiles of deprivation, with almost half of children with type 2 diabetes in the most deprived quintile, the one that's shown in sort of dark orange here on the graph. So this is all obviously pre-COVID statistics. And we've been talking about the North in the previous presentation. These are some of the data from the dashboard shown geographically, and obviously you can see there on the left-hand side that child overweight and obesity is above average in many of the northern regions compared to the southern, and then dental decay on the right-hand side, again, you can see more pronounced in the north than in the south. These are some of there's a range of statistics on there around food environments, but this data presents the density of fast food outlets. Those that have the highest levels of density in the highest quartile are shown in red, and those in the lowest quartile shown in green. We know that the evidence shows that food environments, many of the things that Food Active is working on are really important in terms of shaping obesity outcomes, or shaping diets. And we see this is patterned geographically as well in the UK. So when we're thinking about diets, those of us in public health are often quite focused on the food environments. What we see is there's a situation where if you've not got very much money in your pocket, that situation is made a lot worse by an unhealthy food environment. So the bringing together of a food system which is prioritizing sales of high volume of low nutrient, high calorie food in a situation where we also have marked income inequalities, and this data here presents children living in poverty. Those two factors combined are leading to these very poor health outcomes and these marked dietary inequality, health inequalities that we see across the country, particularly in children, and was reflected also to some extent in Luke's presentation just now. And where that, of course, those two factors come together is in the affordability of a healthy diet. So what we're doing here is tracking over time the price of calories in unhealthy foods, particularly high fat, sugar and salt foods. So this is the red line here is HFSS foods, using the nutrient profile model, which the government uses for various bits of legislation. And then the green line is the price per calorie of, price per 1,000 calories of non-HFS foods. So you can see here there's a sort of threefold differential between the price per 1,000 calories of unhealthy and healthy foods, with not surprisingly, the healthier foods being more expensive per 1,000 calories. And again, concerningly, these two lines are diverging slightly, have been since 2016. So this again is something of concern if we're thinking about how we ensure that people who have got a very low income can secure a healthy diet. This is another type of analysis that we've done on this same problem, which is to compare the cost of the Eat Well guide, which has been calculated by academics at Oxford University. So this is the cost of a healthy diet, essentially, and compare that to income data generated by the Department of Work and Pensions in the Family Resources Survey. And here we look at disposable income after housing costs, and look at how much people would have to spend of that disposable income in order to be able to afford the healthy diet. And you can see here that if you're in the bottom quintile, you need to spend close to 40% of your disposable income after housing in order to be able to afford a healthy diet, and that drops down to 8% if you're in the richest quintile. So we've got a severe problem in the bottom end of this graph in terms of a problem with income being too low, and then you're combining that with a food environment we saw from some of the previous slides, which is prioritizing unhealthy foods, which means that the outcomes are inevitably going to be worst for this section of the population. So I'm going to move on now to talk a little bit about food insecurity and some of the work we've been doing through COVID. So that what I presented just now was really what the situation we went into COVID with. And now, obviously, since March of last year, we've had this huge health shock, but also economic shock. And we've been tracking food insecurity since the beginning of the pandemic. And what we mean by food insecurity is we use a sort of defined measure, which is asking about experiences of food insecurity on a sort of scale. What we present here are data on moderate and severe food insecurity. So this is situations where people have had to cut back on the quantity of food that they're eating, not just the quality, but the quantity, over a defined period of time, and that's sort of determined by the recall periods that we use. And we're particularly interested here in the data presented here in whether people have skipped meals because of lack of money or not being able to get the food they need, whether they have gone for a whole day without eating, or whether they have gone hungry, not eaten and gone hungry in particular circumstances. And you can see here that this is data that presents the first, covering the first 6 months of the pandemic, so March to August of last year, and it's focused on households with children. So 13.6% of parents were experiencing food insecurity. That amounts to about 4 million people, including 2.3 million children. So this is UK-wide data. That compares, you can see there, to pre-COVID levels estimated at about 11.5%. So you can see the level of increase. That increase was very severe in the first couple of months of the pandemic and then improved as that 6-month period progressed. So here we're seeing the average over that whole period. And on the right-hand side, you can see how food insecurity, that 13.6%, is broken down into people that reported skipping meals, going hungry but not eating, or not eating for a whole day. You can see on the right-hand side. And this is data that we gathered from talking to children specifically. So these were children aged between 8 and 17 years, and we did this survey. It's representative of the UK, and we did this survey in September, a couple of weeks into the school term, because we were particularly interested to understand how schools were managing with the provision of school food, and particularly understanding children who were entitled to free school meals and their experiences. But one question we asked was about food insecurity over the summer holidays. There's not very much data to compare this to pre-COVID, because very little has been gathered on children's experiences of food insecurity at all in the UK. Again, we draw on sort of internationally recommended methods for gathering this kind of data. These reflect children's experiences of food insecurity, which are standardized classified in a standardized way. And so these questions were asked in September about the preceding summer holidays, and of course this over the summer holidays there was, for the most part, provision in place to support children that were on free school meals. So many of those families would have been receiving vouchers, though we know that coverage of those schemes was not 100%. And of course, importantly, this data reflects the fact that many children living in poverty are not currently entitled to free school meals because the income threshold is set so low. But here you can see we were really quite shocked when we got this data. 18% of children in this age band reported some experiences of food insecurity over the summer holidays. And you can see that the data here is a mixture of qualitative and quality reductions in food, as well as quantitative reductions in food, but including being sent to friends or family, other extended family, to eat because there wasn't enough food at home. Children seeing their parents not eating because there wasn't enough food in the house. They themselves not eating properly because there wasn't food in the house. So very widespread experiences of food insecurity among children. And I think what we know from the previous data that we presented, that if income is very, very low, households are likely to prioritise the cheapest calories, which are also likely to be the most nutrient poor. It sort of demonstrates that why food insecurity and reports of hunger might well go alongside and be existing in the same households as where children are also an unhealthy weight and may even be obese. So we've got a situation where these two factors are very much going hand in hand, and yet the policy conversation has been quite separate, and indeed a lot of the campaigning around poverty and hunger has not very well joined up with those that are campaigning around reductions in childhood obesity. These narratives have been quite separate, and we believe it's really vitally important that we bring them together to actually look at the problem in its entirety. And then there are some groups that have been disproportionately affected by food insecurity during the pandemic. We know that households with children have been more badly affected than the general population. And here we see the effects of the number of children in your household pre-COVID levels and the sort of 6 months of the pandemic data, showing that if you have a large number of children, 3 or more children, you went into the crisis with higher levels of food insecurity, and you experienced really significant increase. And I think this reflects a number of factors, many of which you will understand well, but I think it also reflects the fact that the way that some of these limits are set around benefits, particularly the benefit cap and also the 2-child limit, really means that households with larger numbers of children have been disproportionately affected. But they are not the only group that have been disproportionately affected. We see really high effects of ethnicity in terms of worsening food insecurity, particularly among Black, other and mixed ethnicity households compared to white. Again, this is 6-monthly food insecurity data in the first 6 months of the pandemic, and you can see there quite significantly higher levels of food insecurity amongst Black ethnicity households, and also very, very marked differences as to whether there's somebody with a disability in the household. Again, these data are very disturbing. I think that 46% of households where an adult reports a long-term disability is of food insecurity, compared to 11% where there's no reported disability. And we see similar patterns for households that report underlying health conditions or have been shielding in terms of elevated levels of food insecurity. What do we need to do to try and tackle this problem? And there's a few things that we're focusing on at the national level. And we've been doing a lot of the work behind the scenes supporting Marcus Rashford's campaign in terms of ensuring that the evidence that he's using is the best quality available. Obviously that campaign has focused particularly on 3 recommendations which were made in the National Food Strategy Part 1, which was published in the summer, which was recommending a relaxing of the eligibility for free school meals and Healthy Start to allow those schemes to include more children. And you'll see here the data presented on the left-hand side. You can see there the total number of school-aged children, the number that are living in poverty going from left to right, then the number that are eligible for free school meals, and then the number that actually consume free school meals on census day. And you can see there that there are large numbers of children living in poverty but who are not eligible for free school meals. And the effort has been to try and ask the government to reconsider the income threshold which determines eligibility for free school meals. And then on the right hand side is
60 seconds.
A similar situation for Healthy Start, where you can see large numbers of pregnant women and children under the age of 3 who are living in poverty but not eligible. So these are obviously in-kind provisions, schemes, which obviously help to create a nutritional safety net for children, and parents say that they help to ring fence household resources for food for children, which they value. But this can't be instead of actually also addressing income problems. And one of the other things that we've been really pushing for is that social security and wages take into account the cost of a healthy diet, because of this data here, which shows the problems around affordability. And the current campaign that's going on to keep in place the £20 lifeline within universal credit is obviously a really important part of that agenda. So just to say, here's the link to the Children's Right to Food dashboard. Also, I thought you might be interested to see here podcasts that we've been doing with young people who are living in disadvantaged circumstances about their experiences of food during lockdown. Hearing their voices is obviously a really critical part of getting the right mix of policies in place, and you can listen to the podcast on the link there. Thanks ever so much.
Fantastic. Thanks so much, Anna. That was absolutely brilliant. Just to confirm, all of that data is freely available through the dashboard, and that's through the Food Foundation site, yeah?
Yeah, that's right.
Fantastic. Thanks a lot for that. Okay, we're going to move on to our final presentation of this section. It's Charlotte Hardman, who is Senior Lecturer at the Department of Psychological Services at our own local university, University of Liverpool. And Charlotte's going to expand on some of those themes that Anna's just touched on, looking more at some of the behavioural issues concerning physical activity and healthy weight. So she's going to talk about the impacts of COVID-19 on food, physical activity and healthy weight behaviours in the North. Charlotte, the floor is yours.
Thanks very much, Matthew. Hello, everyone. I hope you can all hear me and see my slides. Please shout if not. So I'm Charlotte Hardman. I'm a senior lecturer in the Department of Psychology, University of Liverpool. I'm part of the Appetite and Obesity Research Group. And I'm really pleased to be here this morning to talk to you a bit more about how COVID-19 has impacted on our food, physical activity and healthy weight behaviours, with a specific focus on the North. So we've already heard excellent presentations so far this morning on the North-South gap that we see in obesity prevalence and in health outcomes more generally. So these are just some data from the Health Survey for England from a few years ago, which are showing higher levels of adult obesity in the North East, the North West, Yorkshire and Humber and areas of the Midlands. And this is in relation to London, the South West and the South East, where levels are comparatively lower. We also see evidence for a widening of these geographical inequalities. This was seen particularly for women, where, for example, the prevalence of overweight and obesity rose more quickly in the North than in the South over an 11-year period. Of course, we know that obesity is a major risk factor for chronic conditions, particularly cardiovascular disease and type 2 diabetes. And as we know, there's also large geographical inequalities in these health outcomes. So this meant that when COVID hit us at the beginning of last year, in the North, we were already vulnerable. And we're seeing evidence, as Luke showed us, that these health inequalities have been widening as a result of the impact of the pandemic. So many countries throughout the world instigated national lockdowns in order to control the spread of the virus. Unfortunately, in the UK, we find ourselves now in lockdown number 3. Now, of course, lockdown has had far-reaching consequences on people's lives, their livelihoods. The disruption has been really unprecedented. In my presentation today, I'm going to focus specifically on the impact lockdown has had on our healthy weight behaviours, so our diet, our food-related behaviours, and our levels of physical activity. And there are a number of studies which have been published over the past year to illustrate this. There's some data from outside of the UK. So in one study with a small sample of Italian children, it was found that during the national lockdown in Italy, there was an increase in screen time and also an increase in unhealthy food consumption. And then in another study, a larger sample of children and adolescents from Canada, it was found that the majority of the young people were not meeting physical activity guidelines during lockdown. In England, Sport England have been conducting regular surveys on people's activity patterns during the pandemic. And this has shown that physical activity has been really disrupted. But there are specific effects in particular groups who've been particularly impacted. For example, it's been shown that people on low incomes are finding it especially hard to be active during this time. Food Active have also conducted a study with a sample of parents and children aged up to 17. The majority of participants in this sample were from the northwest of England. So their results are very interesting because they suggest both positive and negative changes as a result of the pandemic on diet and physical activity. So on the one hand, parents are reporting having more time because they were all at home more, and therefore having more time for home cooking and fewer takeaways, less eating out. And this is largely because most restaurants were shut during the lockdown, and we know that food eaten outside of the house is much more calorie dense than food eaten at home. And parents also reported some evidence of increased consumption of healthy foods, fruit and vegetables, water, or indeed just some sustaining consumption of those foods. But then on the other side, there were also reports of increased consumption of unhealthy foods like snacks, cakes and confectionery, with the majority of parents saying their children were wanting to eat more snacks during lockdown. And this is possibly due to boredom. Schools were closed for many months during the pandemic, and snacking when you're bored is something that quite a lot of people do. So overall, there were generally split views on whether lockdown made it easier or harder to feed a child a healthy diet. And it seems that the impact that lockdown has had really seems to depend on people's individual circumstances. It's quite hard to predict who might have had a more positive or negative experience. However, we do know from other data, and Anna's presentation has shown this really well, that it's the families who were already struggling financially and struggling to afford food who have been particularly impacted by the pandemic. I just want to say a bit about the mental health impact. This has already been mentioned in Luke's presentation, but there is a lot of evidence that mental health problems have increased during lockdown. And this is relevant here because we also know that obesity and mental health problems often occur together and can exacerbate each other. And one way this might happen is that people can often use food as a way of coping with underlying psychological distress or unmet emotional needs. And this has been highlighted as a particular issue during lockdown. There's been a lot of concern about anxiety in young people and reports that people are eating to cope with this distress. And because we often, the sorts of foods that we often use in this context are higher calorie foods, this can increase our risk of weight gain. So overall, what we're seeing is that during lockdown, there can be direct effects on people's diets and physical activity by curtailing people's opportunities, but lockdown can also indirectly affect our eating and our obesity via changes to mental health. So I'm now going to talk a bit about some research that we did in our group at the University of Liverpool. So one of the things that we were interested in understanding is how have people with a higher body mass index fared during lockdown? So specifically, how have people who have obesity been impacted in terms of their physical activity and diet during the national lockdown? So we conducted a study, and one of the main research aims was to determine whether someone's body mass index is associated with changes to their weight management related behaviours during the lockdown, and also whether someone's body weight might predict the sorts of barriers that people report to engaging in these behaviours. So we've recently published this study in the journal Appetite. If anybody would like a copy, please do get in contact with me and I'm happy to send one through. So I'll just briefly explain our study methodology. So we had just over 2,000 UK adults in the study. They were recruited via the Prolific Researcher panel, and we also used online adverts. And this was in April and May 2020, so during the first national lockdown. Our participants completed an online questionnaire, and they were asked a series of questions about their weight management behaviours. And they were asked to compare their current level of behaviour to their behaviour before the lockdown. So they were asked about weight management behaviours such as snacking and exercising, whether they were doing this a lot less frequently through to a lot more frequently. And then similar for weight management barriers or facilitators, they were asked about the extent to which they've been supported by others to be active or had time to be healthy, to eat healthily, and other similar factors during lockdown compared to before. And again, using that same 1 to 7 scale. And they were also asked about their levels of physical activity using the IPAC. They reported their diet quality using a food frequency questionnaire, and also the extent to which they engaged in overeating behaviours. We collected demographic data, and they also self-reported their height and weight, which we used to calculate their body mass index. So in terms of our key findings, so firstly, just when we look at the data overall, we found that just over half of the sample reported snacking more frequently during lockdown, and then 73% reported that they'd spent more time sitting down. However, on the flip side of this, we found that 60% reported exercising either the same amount or more. So again, here we're seeing this evidence of potential positive and negative effects as a result of lockdown. When we start to break the data down and look at associations with higher BMI, we saw some interesting findings. So firstly, having a higher BMI was associated with a greater perceived increase in unhealthy eating during lockdown and a perceived decrease in physical activity. And we saw this again when we looked at our validated questionnaire measures. People with a higher BMI reported less physical activity in lockdown, poorer quality diet, and higher overeating. And then finally, when we look at the barriers, so we did an analysis here called principal component analysis, where we grouped the barriers into 3 main themes. And these were themes around difficulty accessing food, lack of social support to engage in activity and healthy eating, and lack of healthy eating control. So here people reported issues around finding it quite hard to motivate themselves to eat healthily, falling back into old habits and eating more because of their feelings. And we found that a higher BMI was associated with more difficulties in all of these areas. So just general implications of these findings. We're showing here some evidence that people who have a higher BMI have been particularly impacted by COVID-19 and the lockdown in terms of their healthy weight behaviours and barriers. So people with a higher body mass index reporting lower levels of physical activity, more unhealthy eating, and more barriers to engaging in these behaviours. So this suggests that we really need to be thinking about our approaches that we currently use to support healthy weight behaviours and how we might be able to adapt these to support people with behaviour change during these really challenging and unprecedented times. On the slides here in the bubbles, these are just some of the changes that people might have experienced during the pandemic. And some of these things we really can't control. But there are some things in there that perhaps we do have a bit more control over. And it's a bit like trying to find the best path through the chaos. So how can we support people to do this? So in our group at Liverpool, we currently have a project called Rejoin, which is funded by the UK Association for the Study of Obesity. And the aim of our project is to develop a person-centred intervention which can support people living with obesity with some of these identified barriers to eating and physical activity, which can occur during social and environmental disruption. So this obviously includes the pandemic, but it could also be more localised disruption that an individual might experience, such as their gym closing or having an injury, which means they can't engage in usual activities. So when we talk about person-centred interventions, what we're talking about here is a collaborative conversation style between the individual and a practitioner, and where the aim is to strengthen that person's own motivation and commitment to change. In person-centred approaches, the person is seen as the expert in their own life, and it's about identifying changes that suit them. We're currently in a phase of intervention co-development, and then we're then going to be doing a process evaluation of this approach. We look forward to sharing the findings soon. But these sorts of person-centred interventions work very well because they're very personalised, they're tailored to people's individual circumstances. And that's important for obesity and also in the context of this pandemic. So I'm just going to finish off with my take-home messages. We've shown some evidence that COVID has had a negative impact on a range of healthy weight behaviours, and this seems to be particularly true among people living with obesity. We can use these data to gain new insight into people's experiences and barriers, which can inform the development of interventions. Our interventions need to be tailored to the needs of specific populations, and it's essential that we are not excluding those harder to reach populations, as they are often more affected by obesity. I've just given one example of an intervention that we're working on, but of course these person level interventions are just one piece in a very big puzzle. We really need these structural changes which Anna's been talking about around increasing availability and accessibility of healthy foods as set out in the National Food Strategy, where there are a number of recommendations. So thank you for your time. I will finish up there.
Fantastic. Thanks so much, Charlotte. That was a brilliant presentation again. And just quickly, if anyone wants to find out a bit more about the Rejoin project, that idea of taking more of a person-centered intervention, where might they be able to find out more details on that project?
So feel free to email me. We're in early stages at the moment, but yeah, do email me.
Fantastic. Thanks for that. Well, we're going to turn to a few questions now, a short Q&A session with our panelist speakers, and we've got time for probably about 3 or 4 questions. So I'm going to kick off with one that's come through for Luke. So Luke, and in fact all our speakers, if you just want to come back on screen and open your mics up. Luke, we've got something which is saying the recommendations in your last report have a strong emphasis on addressing child poverty, understandably. How much has the recent support from Marcus Rashford helped wake up the urgency of addressing this with policymakers, in your opinion?
Yeah, thank you very much. Obviously, child health and child poverty have been massive issues for a long time, but they don't get the focus and the attention that they probably deserve, because it's so important. If we get things right in early life, we know these follow through people's whole life trajectories. And I think it's quite good what Marcus Rashford's doing, but also quite sad that it takes a high-profile celebrity to highlight these issues. Policymakers should be aware of this. It shouldn't take a professional footballer to highlight the injustice of what's going on, and there should be more knowledge of this. But that said, it is a positive step. Obviously, we just need it to continue beyond the pandemic and not be a short-lived thing where as soon as hopefully this is finished, people forget about it again. So yes, I think it is massively important, and what Max Rash is doing is brilliant, and hopefully it does have long legacy effects.
Thanks very much. And now one for Anna. Anna, somebody's asked, can we get the food insecurity data at either a regional or even local level? And is there any data on 0 to 2-year-olds and nutritional deficit?
There's food insecurity data is available at regional level,
okay,
but not below that, unfortunately. Though pre-COVID, there was a big survey in London, so there's quite detailed data for London on food insecurity pre-COVID, but certainly since COVID, there's only regional. Good question on under 2s. I'm not aware. I mean, there's a little bit in NDNS, I think, but I don't. Others may be able to correct me on that, but I think generally it's quite a big data gap, and the infant feeding survey that used to happen no longer happens. So data in that area is not brilliant, to be honest. It's a gap.
So yeah, okay, so further research definitely needed in terms of that segment. Yeah. Okay, Charlotte, just one through for you. Somebody's asked, how much do you think mental health issues have been a factor in the rise of overeating and eating unhealthy foods reported in your recent research to do with lockdown and COVID?
Thank you. Yeah, I mean, that's a great question. And I didn't have time to go into sort of the intricacies of the data, but we did run that analysis and we found that people who had more of a decline in mental health problems showed greater increases in problematic eating during lockdown, which resonates really well with some of the other data that we're seeing coming out. And I think, yeah, it's very concerning when we see the increases in mental health from an economic perspective, a health perspective, but also for that they're potentially having this indirect effect on obesity, which I think people can be a bit less aware of that one. And obesity is just so complex. There are so many different drivers, and it's really important that we take all of those into account.
Okay, and just one quick one, just to finish, really good question here. Anna, this has come through to you actually. Fascinated to know what you think about. Why do you think that the take-up of Healthy Start has actually been so low?
I think there are a number of reasons. One is that over time the value of the voucher has depreciated. It wasn't until the government announced it was going to increase it, which is due to happen in April of this year. The number hadn't been looked at for 10 years. So overall the value of that voucher was going down. I think there have also been a number of real implementation problems. And since COVID, you're no longer required to have a health visitor sign your form, which I think the Department of Health hoped would make it easier for people, because people getting less access to health visitors. But I think perhaps one of the unintended consequences has been that actually health visitors were signposting people much more and helping them go through that process by virtue of the fact they had to sign the form, and that is no longer isn't happening as much. So there's a bunch of implementation issues, and I think the fact that the scheme is so small also means it's quite hard for retailers to really promote it. And we've been doing a lot of work with the big retailers to get them to add value to the scheme, add extra fruit and veg to the scheme. So that will start, I think, to make the scheme a little bit more visible. But we're really encouraging the Department of Health to do a really big kind of comms campaign around the scheme to try and drive up uptake. It's desperately needed.
Cool. Okay, brilliant. That was a great answer. Thanks very much. And thanks to all of our first three speakers for today's conference. A great scene setter for the rest of the day's proceedings. So I'm going to now invite Janelle DeGruchy, who has now been able to join us, to come online. And Janelle, as you may well know, is the president of the Association of Directors of Public Health and also Director of Public Health at Tameside Council. And Janelle's going to take us through a panel discussion with DPHs on their experience and perspectives on opportunities for addressing obesity and inequalities in the North. So I'm going to hand over to Janelle to introduce our panel, and many thanks for joining us.
Thanks, Matthew, and apologies I couldn't be with you earlier. I caught a bit of the Q&A there and quite a bit on Twitter. So it sounded fascinating data and evidence that's coming through. And I guess the panel now, the discussion is about on the ground. How, what are the opportunities, given the evidence that you've been looking at this morning, what are the opportunities for addressing obesity and inequalities in the North? So the Director of Public Health and our public health teams, local public health teams and Public Health England colleagues working regionally and locally, what are our experiences and our perspective on what the opportunities are in the face of, what we're all coping with just in terms of containing COVID. What more can we do as hopefully in the near future we start to move into a more recovery phase. So I'm really pleased to introduce the panelists. So we've got Peter Kelly, who's from the Northeastern Yorkshire region, Regional Director of Public Health, Matthew Ashton, DPH in Liverpool, and Fiona Phillips, who's an Assistant Director of Public Health in York. So welcome to you. I'm going to ask you the first question, really. From your experience over the last 10 months, what do you think the opportunities are for addressing obesity and inequalities as we look to hopefully move into the recovery phase from COVID? And I guess I'll just add a bit: is there more we should be doing now during, whilst we're in the hurly-burly of containing COVID, but as we then look forward to recovery, what are the opportunities? So should we start with Peter? I'll go in that order, and then we'll mix it up in the next question.
Thank you, Janelle, and I'd just like to thank the speakers, Luke, Anna, and Charlotte, for 3 excellent presentations there, really thought-provoking. And one of the opportunities attending an event like this gives me is a chance to step back from the hurly-burly of the world of COVID, but also to think about the recovery in the future in the context of this critically important topic, inequality. So thank you for giving me that opportunity as well to think about that for a little while. So I'll be relatively brief in terms of and try and stick to the question you just asked me, Janelle. So I think in terms of obesity and inequalities, and take the two together, I'd suggest a couple of emergency measures. So I was quite taken by Anna's comment, which I think many of us would empathise with, that the threshold for free school meals is too low. Now, I would remove the threshold completely as an emergency measure. I think as a country, we ought to be thinking about recovering from this crisis, and the crisis that our children have faced, and the children have borne a huge brunt and paid a huge price in terms of their future prospects in education. And I actually, and this may be controversial to some people, I would actually have breakfasts and lunches for every child in the country for the next year in school. It takes away stigma, improves nutrition enormously because you can control what they eat. It would help families who are lower income families, and yes, it would help middle and higher income families, but actually it takes all the stigma away and it's about leveling up. So let's help those families at the bottom the most. Give their children good quality food for a year as an emergency measure, because I think we have an emergency with childhood nutrition and the growing obesity problem. So there's just a very concrete proposal. It would cost a fraction of the 22 billion we spend on test and trace. It would cost a fraction. So it is certainly something, and it's achievable and doable and practical. It would simply take political will. So there's a suggestion. You've asked for ideas. There's an idea. I think would also help reduce inequalities. Secondly, I would like to see a whole debate reopening about children's education. We need smaller class sizes. We need more teaching assistants. We need children who have, from the most disadvantaged areas, need more teaching assistants in class to help them. We've got to build the confidence and self-esteem of young people. There's a poverty not just of money, but there's a poverty of education, a poverty of hope in these communities. We've got to rebuild communities who are struggling the most, build their self-esteem, build their hope. I heard somebody on Radio 4 this morning coming in, and they said, we don't have hope, what do we have? So we need to give hope to these young people. One of the inspirational thing at Marcus Rashford for me isn't just the fact what he's doing, which I think is wonderful, but it's how a young black lad, disadvantaged, such a hard background, can become an international superstar, and then hasn't forgotten, does all the good things he does. We want dozens and dozens and dozens and hundreds more of them, rather than being the exception. So I'll stop there, because I could talk forever on this, as you know, Janelle. So I'll stop there, let other people come in, and we'll have a conversation. But there's some ideas.
So you've gone for the big, hard-hitting, big policy statement. Interesting, great, and I think for years to come, we'll all the benchmark will be, this will be less than what test and trace has cost. I'm sure that statement we'll be using that statement for the next 10 years. So with that, Matt.
Thank you, and always difficult following Peter, so thank you for that. Thanks to the speakers, by the way. I thought they were brilliant and quite inspiring. I think my first observation really probably isn't an opportunity, it's a reflection on how hard the last year has been for everybody. So obviously for our communities, obviously for people directly and indirectly affected by COVID, but from a professional public health perspective, how difficult it has been to do what we would traditionally call the day job, because we have been wrapped up in COVID response all the time. which unfortunately makes you feel a little bit inadequate when you come to conferences like this and hear about all the stuff that you should have been cracking on with if COVID hadn't have got in the way. So I think that's my first point: significant disruption over the last year. Hopefully, and listening to Chief Medical Officer last week, this is the worst it's ever going to be. So it can only get better from this point onwards. And as we move into that recovery phase, I do think there are opportunities that we absolutely need to grab hold of with both hands, and there is an expression, isn't there, never waste a good crisis, to progress kind of policy and strategy changes. So the pandemic has absolutely shone that light on inequalities in general and the impact of inequalities, but specifically around some certain aspects like obesity, healthy weight, and mental health and well-being. And we need to not lose those the opportunity that this presents us with. And I think that absolutely has to be the combination of both local and national action. My fear is that once the pandemic, the crisis is over, we go back to normal, and that normal kind of dealing with politics and indecision and things that seem logical from a public health perspective taking a lot longer to get over the line. And I think we therefore need to be louder in our advocacy voices around demanding those changes to kick in to prevent us being in these kind of situations in the future. I'm absolutely fascinated by the Marcus Rashford effect, and there are other players in there, but Marcus Rashford obviously is the one that's had the biggest hit, but Jordan Henderson at Liverpool in addition to that. Because it strikes me it's been a different kind of celebrity campaign, this, driven through personal experience, personal lived experience, personal knowledge, and absolutely a personal desire for him to make a difference. Whereas perhaps in the past we've used celebrity endorsements, but used them in a softer way just to get a quote out of them. So I think there's an opportunity to think through strategically how we identify the right celebrity is an awful term, isn't it? But how we identify the right celebrities to push forward public health agendas in a different way from how we've done it previously. And then just two more: the partnership working that we've seen at a local level, I think, has been phenomenal. And again, that's that kind of crisis effect. Everybody pulls together to try and be part of the solution, and we absolutely need to hold on to that partnership working approach. So, co-design, co-production, led by our communities, informed by our communities, and driving solutions that way. And then the final one I'd say is the media, and I do think certainly from a local media perspective, our media have played an absolute blinder in supporting some of the key messages we've had, and especially when you think about kind of some of the backlash that we get from social media and some of the challenges we get around that. And then just to really specifically, I'm really interested by Peter's point about breakfast and lunch for everybody for a year. If we're being brave and bold, they're the kind of policy decisions that need to stick longer term. So I absolutely get the sentiment, but I agree, we need to have a change to the way we approach school and the support around schools. So free meals for everybody, good quality meals in a school environment that reduces stigma but improves people's lives overall. And if we're being really brave and bold, can we readdress the balance in the curriculum as well? So it is about learning, but it's about whole life learning. It's about mental health and well-being. It's about physical activity. It's about healthy eating, as well as doing all the English and math stuff that I can barely remember, but my 7-year-old tells me I get wrong constantly. Thank you.
Thanks, Matt, and I do hope your maths does come to pertain when you look at the data. I'm sure you do. I'm sure you do use it. But thanks. Some fantastic comments and thoughts there. And interestingly, it is about the local, but so important that link through from the national. The local. Actually, what we need is it all lined up. There isn't anything sort of different in terms of us working locally, is it? I mean, we need everything lined up to really work for local communities. So great. So with that, I'm going to go over to Fiona. Your thoughts, Fiona?
Yeah, so it's hard to follow those two comments. So I suppose just building on what you were saying there, I suppose I wanted to reflect a bit more on the kind of local and some of the things that have kind of happened in that very kind of local arena. So I think one of the big changes that we've really seen, and it's kind of casting your mind back to some of the stuff from the early 2000s, and in particular the Oneless report, and talking about this fully engaged scenario. And one of the things within that was, that actually people wanted more for their health, that people were kind of engaged with the health agenda. And so I think what COVID has really done, particularly in sort of local communities, is to really get people engaged and see that actually why some of these bigger health issues are, that they should be paying attention to, and that they're more ambitious for what they want in terms of their own health, and they can see the impact. What COVID has done is kind of really fast forward that, having an issue like obesity, that really does have an impact on your chances when it comes to other health conditions. So I think kind of trying to engage and make the most of that kind of ambition within your local populations is really important. And then also I was reflecting on some of the work that we were doing probably last summer when we all started talking about our recovery from COVID and what our local response to that was going to be when, perhaps in the summer we thought, this is it, we're over the worst. And some of what happened in our local area was that change in a dialogue around actually health has to be at the heart of everything we do within the council and within our local systems. And I'm sure many of the people on the call were probably involved in similar conversations at a local level. So I think really kind of now there are opportunities, people are taking it seriously around health, and particularly that, finally there's that recognition that, health and the economy are so intertwined, you can't have one without the other. So I think there are real opportunities in some of those conversations that are happening at a local level in terms of what the direction is in terms of building back economies at a local level, and how health has to be a really key part of those conversations. And then also in terms of, some of the work that happens on the ground to support communities and help to reduce inequalities in communities, and that kind of recognition that our voluntary and community sector is so important in how we work with local people, and that recognition that we need to do all that we can to support that sector, because actually without a strong voluntary and community sector, we're going to be really struggling to reach some of the communities that we really want to work with.
Thanks, Fiona. Really interesting, isn't it, about how COVID has both, forged or strengthened that connections into the community and voluntary sector. And I know locally in Tameside, we've certainly I think really that initial going into first lockdown, that huge humanitarian response, partly also for what we received from National in terms of, the Angel Delight and that kind of food. I don't know if it's been mentioned earlier this morning, but, locally us having to go, what, we need to do better here, and doing that with local partners, both different and new, strengthening the COVID champions, those kinds of things. So I wonder, Fiona, you kicked us off there. I don't know if you had one or two more thoughts about that. And then I think if I can adapt some of the questions panel to go a bit more into that, both sort of regional and local, what kind of partners do you think new, different or strengthened there have been locally that we can then build on in terms of taking forward this agenda into the recovery? Fiona, do you want to start, and then we'll answer that question, and then I am going to open it to the audience, just in terms of time. But let's go with that one, Fiona.
Yeah, so I think definitely there have been really good partnerships developing at local levels. I think some of my reflection has been that some of them are not new partnerships, but there's a newfound respect within partnerships. So think about schools in particular. We would have always said we work really closely with schools and we have good relationships with schools. But I think it was maybe in a kind of a way of an old married couple type partnership, in that we kind of rubbed along beside each other, we nagged each other a bit, and we generally got on all right, but we were maybe a bit annoying to each other at times. And what I've kind of found through COVID is that we've actually taken a real genuine interest in each other and the problems and issues that we're dealing with, and we've really listened and actually really wanted to understand what's happening in that setting. And then I think there's been more trust. So I think our school leaders would say that they really trust that their colleagues in public health have got their back. But I think similarly, we would say the same about our school colleagues, that we are really trusting that they really want to do everything they can in terms of the COVID agenda. So that real kind of, so it's not a new relationship, but building on that trust now and thinking about how do we, coming out of COVID, how do we maintain that? And I think some of that relates to, we've talked about, COVID has kind of been the one thing that we're all working to mitigate risks around. So it's kind of, how do we have that kind of shared understanding, really understand each other's priorities and say, what is the one thing that we all want to do and work together to address?
Thanks, Fiona. That's really interesting. I love that we were an old married couple before in our partnership, and this has moved things forward or differently. Particularly with the schools and the head teachers. I won't ask you to characterize, and then the trust. I won't ask you to characterize the relationship with the head teachers and the DFE through COVID, and we'll leave that one for another time. We might have a tweet we don't want. So with that, I'm going to move on to Matt.
Yeah, I agree with Fiona. Not necessarily new partners, but a new dynamic, a new relationship with them. So absolutely a focusing of the mind, and public health, directors of public health, but public health agendas thrust right into the center of that, which obviously we would all rather not have the pandemic, but it has presented interesting opportunities for us. So although I have always worked with our schools and our voluntary community faith sectors, now I'm having weekly meetings with our faith leaders and with our business sector and having really interesting conversations with them, kind of illustrating the point that we are all in this together. We're all dealing with these challenges, and we might come at it from a slightly different angle, but it really is about both wealth and well-being. It's the economy and health. So absolutely agree with Fiona. Trust and respect and a new focus, which has been absolutely brilliant. I think there's some interesting learning for the public health community in that space as well, because we like to think of ourselves as the experts, and from a DPH and a consultant perspective, we train, we do this stuff, we are qualified, and so how dare anybody else tell us what the right answer is? But actually, the strength of the partnership working here has shown to me that if we wind people up and set them off in the right direction, they will do a phenomenal job and they will knock it out of the park, and they really kind of get it and understand what it is we need to do collectively, and will bring their own ideas, energy, solutions to the table. So not necessarily new partners, but a change to the way partnerships have worked. And I think there's also an acknowledgement within that it isn't public health or public health teams that hold all the answers. It's collectively, it's our communities, our residents, our systems that hold the answers. We can't do this stuff by ourselves, and nor should we.
Brilliant. Thanks, Matt. Move on to Peter. So at the regional level, Peter, what are you seeing in local areas?
Absolutely. My youngest brother's a head teacher, by the way, Janelle, so I get all the, you can imagine the rant he has at me the weekend. So my role, so just for colleagues on the course, as regional director, I cover Yorkshire North East, which is 27 local authorities, 8 million people. And my most important partners are 27 directors of public health. And I am crystal clear about that. I was crystal clear about it before COVID, and I'm crystal clear about it during COVID. So first and foremost, in terms of partnerships, what my experience, and I suppose you have to ask them as well, but I think the partnership between the public health world, first of all, is really strengthened. Certainly in our experience, I think it was already strong. I think we're starting from a strong base, but I think it has strengthened. In a regional place, it's absolutely not my place or my team's place to interfere locally or to intervene locally, but it is our place to support local, to advocate for local, to advise local when our advice is sought, and to protect local as well, because we do a lot of that. So the partnerships we have, we have and we work with them. What I've seen happen, and what I think we have, we've contributed to as a catalyst for some things. I'm seeing far greater cross-party political support work, actually. So I'm seeing authorities who previously would barely speak to each other in really good partnerships across all parts of Yorkshire and the North East, to the point where I've seen leaders from opposite political parties who in most things would have, completely legitimate political differences, agreeing to support the other and not go into lockdown without the other, or not to come out of lockdown without the other, in ways which I'd never dreamt would have happened. So I think actually seeing that type of partnership, I think, is for the benefit of the people they all serve, whichever political background they come from. So I think that's been massively reassuring to me, and gives me hope for the future system. I think partnerships between the big public bodies are very important. We've talked about at low level. I mean, Matt's work talk with faith communities right on the ground at micro level is massively important. It's also important to get the NHS at big level, talking to local government at big level, and bring them closer together. So part of our role and my team's role is not to foment a difference between us and them, but to bring closer together. And I think there are examples where we've managed to do that. And I'll go beyond just the very big public sector bodies, although we focus on them because actually that's where a lot of money is and resource, but also the various third sector groups. And in the middle of all of this, we've persuaded in parts of the region for ICSs to increase their investment in non-COVID public health. We've had funding for tobacco and alcohol confirmed this week from the NHS over and above any allocations. We've just got some more money for them through the work of the joint work between the DPH and one of my team. It wouldn't happen. It needed both of them, and those partnerships make a difference. So for me, it's been a strengthening of partnerships at all levels. I can't think of any partnerships that have weakened. I think, and underneath partnerships are relationships, and relationships are built on trust and shared values. And I think as a public health world, we know that we have those shared values and that trust, and so I've seen a lot of that strengthened, and it's as we come out the pandemic and we recover in the future, we've got to build on those relationships and that trust, however we all come out of it, and use our talent and skills and knowledge to build a better future with those partnerships. I want to see particularly local government groupings who previously didn't talk to each other continue to work to each other on economic development and the type of things we would all want to see to level up around Luke's talk, level up the economy. We don't do it by being in competition, we do it by working together.
Thanks, Peter and other Matt, Fiona. I think it'd be also, I think your point about strengthening the public health system is a really important one, Peter, particularly in face of challenges with how other systems also have been set up. And I guess going forward for 2021 is going to be a real challenge in terms of Public Health England, future direction, the National Institute of Health Protection, and what happens to the health improvement element, and therefore what happens around obesity. I think that is one to watch. We need to absolutely build on the strength that we have through COVID, but I think it is going to be really quite challenging. So not for panel today, but I just wanted to flag that up as in terms of non-COVID stuff. I think we have to absolutely be thinking about it and what happens in the face of, and given that. So we've had 2 questions come in that Beth has sent me through from the audience. So I think, given the time, we've got about 10 minutes. So we'll go back through the panel, but I'm going to ask both of the questions because I think it's only fair for the panel to have a bit of a choice. Indeed, but please, the 2 might be related, maybe. So the first one is, we did mention, or Fiona, you particularly, Matt, mentioned a newfound respect for community and voluntary sector organisations and what they can do and how they're embedded within communities, but also responding to the pandemic. How can we ensure this continues beyond the pandemic, and how do we really place local communities at the heart of our public health strategies? So how do we build on that? And then the second question is, from that real rooted in the community, what are our thoughts on the National Obesity Strategy published back in July? How much do you think it will support the reduction in levels of overweight and obesity in the North? So 2 kind of different questions, really, but just to have a think about that, and either respond to both or one of those. So I'm going to start with you, Matt, I think, on this one. And then I'll go with Peter, and then Fiona wrap up.
Okay, thank you. I've always massively enjoyed working with our VCF sector. I think they bring energy and ideas to the table that perhaps the public sector doesn't always get. And so particularly in Sefton, before I moved to Liverpool, did a whole series of work around what was called Well Sefton, and investing in our communities and using that as the drive. And there's loads of different benefits to it, not just the projects themselves. But funding is a permanent challenge with the voluntary community sector, as we know, and often they are relying on short-term grants, short-term funding, just trying to make ends meet, that month or that quarter. So there's something about how do we channel as much of our public monies into VCF as appropriate and as possible. In order to do that, that's about joint work, that's about collaboration at a local level, local partnerships with true collaboration, true co-production of solutions, and making sure that whatever the right words are, but fair shares funding, that the money is getting to the people on the ground who can actually make a difference. And we know from all the economic analysis stuff that from a value for money perspective, our voluntary community sector knocks it out of the park. And I think that's the approach I've always used, but I think it's absolutely essential we do that. There are obviously always going to be funding challenges, certainly in the near future, for all of us, and I'm sure the voluntary community sector will be feeling that pain as well. I think that there is also, though, something around the way the voluntary community sector work with each other, which is a challenge, because in a way they're all out there with their elbows out fighting for those small pots of money as well. And so whilst we can bring people to the table, we need people to collaborate with each other as well as with us. And that's that bit about, it isn't competition, it's about true collaboration across the sector. So some more that we can do at a local level, but more that the VCF sector can do as well.
Great. Thanks, Matt. I'll come back to you, actually, if you want to have a think about the strategy, actually. But let's go on. Peter, your thoughts?
Yeah, I'll actually, I will answer the community question, because I've been DPH for many years in different places as well. For me, I'll just I'll follow one of Matt's points and just add a couple. So funding's really critical. Because we have to be careful that the public sector doesn't think we're getting just this for free. We have to recognise there is a cost as well to properly support and train the voluntary sector, and we've got to get rid of some of the bureaucracy. So we try to support the voluntary sector, and then we make them fill in a business plan that would take a band-aid the NHS manager three weeks to complete. Then we wonder why they don't, they struggle to win some of the bids, and we don't support them. So we've got to remove some of the bureaucracy, and we've got to be clear on the outcomes we want them to achieve, but those outcomes should be locally focused outcomes around participation and process outcomes. Because if anybody thinks we'll turn inequalities around quickly, as we know, they are mistaken. So you have to rely on some surrogate process outcomes around and build local community capital, and you do that by investing over time. And I think that's really, really important. And finally, something which and I initiated in two councils I worked in, well, both PCTs and the council. I've always found small grants really useful. Small grants you can actually, and when I was a DPH at Stockton, I set aside a part of the public health grant deliberately for small grants for local VCS communities. And then I went further, because initially we distributed it. Then I said no. I went to the third sector. I gave them all the money. Said, right, you distribute it. So I just literally sliced the budget. Obviously I had political support overnight to make sure the members agreed, but the members thought it was a great idea, so we just did it. And even now, after I've left 4 years ago, they're still doing it. So I think there are some things you can actually do, and really, and local communities sometimes know their priorities better than us. Actually, the local VCS. So let some of them decide some of the priorities. So there's some ideas and communities. I'll maybe come back to the strategy one as well separately.
All right.
Janelle.
Okay. Yeah. Okay. Well, let's do that. Let's do that. Fiona. So, are we going to put our money where our mouth is?
Yeah, I mean, I think Matt and Peter kind of hit it on the head there, really. We know that businesses have struggled through COVID, but equally, the financial position that many of our voluntary organisations are in, is worse. And so if those organisations don't survive and aren't there, we're not going to move forward with this at all. So that's the kind of, the real number one priority that we need to have. And also, that equal partnership as well, respecting the knowledge and understanding of the communities and, giving them the autonomy to set some of the priorities is really key as well. And then I suppose one of the things, voluntary organisations do rely on people to give up their time and do voluntary work. And I think one of the key things is that we really need to look after those people in our communities that do that. Somewhere like York in particular, it would be the same in other places too, but just before COVID, we dealt with a significant flooding issue. We've dealt with flooding again just a few weeks ago. And then all the volunteers who've given up their time through COVID, people are getting tired, and we need to not take for granted that will within our communities to give up time. So I think, what more can we do to look after those resources that we have within our communities and not take it for granted, and make sure that we properly resource our voluntary organisations so that people will still, give up that time and see it as a worthwhile thing that they want to do.
Thanks, Fiona. That's great. So it's money, and then well-being, isn't it? Sounds like the answer. Great. Okay. Well, let's. We've got a few minutes. So let's go. Matt, your thoughts on the National Obesity Strategy? How much do you think it's going to actually support reduction in the levels in the north, especially given everything?
Yeah. So look, the strategy's got welcome elements. I think we appreciate the stuff around kind of food promotion, action on junk food advertising. Perhaps still too much of a focus on the individual within it, and so still more we can do. I think also it needs to be more than just words on a page, and it really needs to be actions delivered across government, so not just owned by the Department of Health and Social Care, but across governments. And just to kind of illustrate that, we had I'm going to use the words, we had the nonsense of the Eat Out to Help Out campaign at the end of the summer, and wouldn't it be really interesting if we could reverse that and actually have Help Out to Eat Well or something like that absolutely spoke to kind of to food, nutritional standards, education and the economy all at the same time. I think there are things in the strategy that need to be kind of stronger, so more mandatory rather than voluntary, not just on the individual but on business, so nutritional standards and those kinds of things. And this stuff does need to be led by governments. That's why you have a national strategy, but everybody needs to be able to play their part in it. So we've got something and we can build on it, and we absolutely should build on it, and we have to keep on pushing to make sure the strategy delivers its aims and objectives. And actually the aims and objectives are good. The stuff that Matt Hancock talked about and the obesity strategy, and indeed the Prime Minister talked about, they are good aims and objectives, but you don't do it just by having words on a page. You do it through delivery, through action. And that does mean we have to hold business to account for delivery on their elements. And that's the bit that I guess we're all a little bit worried about whether we actually do go hard on businesses that don't meet that. And then just finally, there will be things to play out around Brexit that I'm not sure what that will look like, and I'm guessing maybe more intelligent people than I do, but it might take some time for that stuff to settle down, for us to truly understand the impact of Brexit on food supply and on manufacturing and those kind of things that will impact on the delivery of the obesity strategy. So let's see this as kind of a step in the right direction, needs to be enacted, but then needs to be developed as the context around us changes from pandemic recovery and from Brexit.
Thanks, Matt. I love that. Help out to eat better, or help out to eat well. And I guess the supermarkets haven't exactly covered themselves always in glory around COVID. So how do we push on in terms of their corporate responsibility in eating well? It's going to be tough, isn't it? Peter, 30 seconds before we have to
very balanced comments from Matt. I agree with him. I'll focus on just one thing in the remaining 25 seconds. If we tried to treat our way out of this, the weight management or individual responsibility will fail. Full stop. Because it won't work. It never has done. It won't. So what we need to think about are the system changes. I'll leave it at that. But if we try just do a weight management approach and it's all your fault, blame people, it ain't going to work.
So
and it'll actually widen inequalities. I'll finish with that bit.
So Peter, again, I suppose you bring it back to what's going to happen in terms of PHE and the change in terms of health improvement.
Yeah, I wasn't thinking of those.
No, I know you weren't thinking of that. I'm thinking of it.
Yeah, sure. Yeah.
And the NHS. Well, the point was the NHS can't be the lead champion on this, can it really? Because its strength is perhaps more around certain weight management programs and so on. Fiona, any last thoughts, or are you happy to leave it there?
Well, I mean, I echo that and just say that the more exciting part of the strategy for me was in terms of the stuff around the restrictions around foods that are high in fat, salts and sugar, some of that environmental stuff rather than the focus on individuals. So absolutely agree with that, and looking forward to what the National Food Strategy Part 2 might say as well.
Great, thanks very much, and thank you to the audience who have been sending through their questions. Unfortunately, we've run out of time to look at them. There were some great questions there about the link to planetary health. So we could have gone from the national strategy to what's our planet strategy, back down again in terms of social injustice around communities' access to local places or even to the kinds of shops. So real, wider determinants on the ground, what's happening, social injustice stuff there, to some questions around particular community hub initiatives and so on. So thanks very much. And thanks again to our panel of speakers, very interesting thoughts and proposals, really, policy proposals, which ADPH we might look at to take forward. Matt, what do you think? So with that, I'll hand back to Matthew, because I think you've got a short break now.
We do, but thanks to you, Janelle, for sharing that expertly, as one would predict, and also to Peter, to Fiona, and to Matt for some fabulous contribution, and really interesting to hear from DPHs about, a step in the right direction in terms of the obesity strategy, but it's about action, and hopefully some of the policy calls that we will announce later today through our 8-point policy call specifically for the north of England is going to add weight to that, and also to call for action from our Metro mayors as well. So thanks for that. And we're now going to move into a short break. So if you could rejoin us at 11:30 sharp, we're going to go into some workshops. There's 2 workshops that we'll work through, and then we're going to have that 8-point policy call. But a quick thanks to all of our panelists again for this morning, and see you back here. Go and refresh yourselves, get a cup of coffee, and see you back here at 11:30. Many thanks. Okay, folks, we're going to start again just in about 30 seconds. Thanks. Well, welcome back, everybody, if indeed you are back at your desks yet. Takes a while to make a cup of coffee. I only just made it. So anyway, we're going to queue to all of our workshop speakers, some brilliant workshops. I dipped in and out of a couple of them. Some really interesting stuff in the first one on one of the Sport England local delivery partnerships, and some great work from Leeds that I just listened to in terms of their adoption of the healthy weight declaration and that ability to work across the system in terms of healthy weight. So we're going to move into a final session now, just 10 minutes, and we're going to launch an 8-point policy call, and this is going to be a policy call which is specific to the north of England, and this is really coming off the back of some of the conversations that we've already had today, and it's a challenge that we're going to put in front of the metro mayors and combined authorities across the north of England to basically take this on as a specific set of policies that are pertinent to the north in terms of closing that inequalities gap and hopefully reducing levels of obesity and overweight within our region. So where has this come from? Next slide, please, Alex. The evidence base for urgent action on healthy weight and health inequalities in the north of England is overwhelming. We've seen that already this morning, not just the outcomes from the pandemic, but those foundations, those preconditions that Luke talked about early this morning. And COVID's just only exacerbated this. And the UK government's obesity strategy, one of many over the last number of years, in our opinion, at least, it's only going to go a small way to addressing overweight and obesity across our populations and age groups. And it was interesting to hear some of the DPHs talk about, great start, but this really does need action. And it's not just rhetoric that needs to be coming from government. So we think that a specific set of policies for the north of England is needed to kickstart tangible change that can be facilitated not just by local authorities, but through NHS structures in the form of anchor institutions, through transport providers, schools and early years settings, and also the local and regional media. And we've worked with key stakeholders, local authorities and combined authorities to develop an 8-point policy call that we're going to reveal now. And we're going to be taking this to the metro mayors as a key strand for building back fairer in the north of England. So I'm going to hand over to Alex now to sort you through those 8 policies and how you can then follow this up, hopefully with your support. Alex.
Thanks, Matthew. Okay, so as Matthew said, I'm just going to run through the 8 points on our policy call. Each policy is supported by an evidence base and a rationale. But for the benefit of this presentation, we've just kept it simple. So as you can see on the screen, our first call is that healthy weight in all policy areas is embedded across local authorities and combined authorities in Northern England. Number 2, taking learning from the work that's been going on in Greater London, we would like transport providers to ban advertisements for food and drink which is high in fat, salt and sugar across all northern transport networks. We want to see access and purchase power for healthier food increased for those who live in the poorest areas of the north through subsidies. We will lobby for effective powers for local authorities to A, restrict less healthy food outlets, and B, improve the access and nutritional quality of food provided in educational settings, to increase the level of teaching supported schools, and to a refocus of the curriculum to include health and wellbeing at its core, and there will be accountability for this. We will call for metro mayors to lead on the formation of combined authority food boards, again taking learning from London. And we will inform and empower local and regional media to avoid weight stigma and discrimination when reporting on overweight and obesity. We will call for increased spending on active transport infrastructure across the north of England. And finally, we will ask government to review the local authority spending per head to proportionate support to reduce inequalities, supporting healthy weight through preventative policy and localised support. So just briefly, the next steps. So we will be contacting local authorities to request support for the policy calls. And as part of the follow-up to this conference, we will be asking for your support. We will lobby the Metro Mayors for their support also. And once we have this high-level support in place, we will pull together a working group to drive action. So just a thought to take away from this session. Do you think your local authority or organisation will sign up? Thank you.
Thanks very much, Alex. And it's nice to see quite a number of those policies reflected in discussion earlier today. It was interesting to hear about both Matt Ashton and Peter Kelly talking about the need to reposition health and well-being as part of the school curriculum. So anyway, we'll be following that up, as Alex suggested, with you after this conference, and hopefully gaining your support and getting a real movement together in terms of that policy call. So I'm going to wrap up today now, and just perhaps a few reflections on what we've heard. I think one of the messages that has come out most clearly is the continued need for partnership working across the system. And it was really interesting to hear about some of the new partnerships, or a kind of perhaps a recasting of existing partnerships, and some of the incredible outcomes and some of the achievements that have been reached in terms of local authorities, NHS, voluntary sector, faith sector, businesses all being worked together in terms of overcoming some of the problems presented by the pandemic and lockdown. And I think co-creation of policy making and interventions is another thing that has come out most clearly today. But perhaps more than anything else, it's about action. It's about action now. And we realize that the pandemic has completely preoccupied, well, everyone, but certainly DPHs and public health departments, and quite understandably. But the need for prevention and the need for adequate policies and interventions that can address rising levels now of overweight and obesity within our communities is absolutely paramount. And it's about action, not strategy. But of course, this will need funding. And hopefully that is something that will not go past government as we move on. So a quick thanks to all of our speakers for giving their time up to contribute today and giving their time to prepare and deliver presentations. It's a really challenging time, we realise that. Thanks to all delegates for joining us, of course, and we do hope that you found the conference useful. And we will be circulating presentations next week via email. There is a very short survey that we're going to circulate inevitably, so please do complete this, as we do appreciate your feedback. And so thanks for attending. And I'm amazed we have finished bang on 12:30. I don't think we've ever done that for a conference before, quite frankly. So just a quick final thanks though, and it's to the Food Active team, to some fantastic members of staff, in particular Beth Bradshaw, who's organised this conference and put most of it together, ably supported by Alex as well. So a big thanks to Alex Holt and to Beth Bradshaw and to the rest of the Food Active and Health Equalities team. It's been fantastic. Thanks for joining us, and hopefully we can all meet again physically next year. But if not, stay safe and have a good day. Bye for now.